as well, because their career growth and all are actually put on hold for this child actually. And they have intense emotional and physical toll as well. So what was the nutshell that came out of all this is that the past mindset is fixing the child. We are trying to fix the child. Don't try to fix the child. Find out his individual strengths and try to work on them. Second is we try to focus entirely on academic certificates. Shift the focus on independence, self-care, and life skills. Isolating the child to hide his non-typical behaviors. Please try not to do that. This is the request of the parents. Try to adapt the environments to fit the individual. So one of the parents said, I spent all these years trying to make him normal. From that, we have to shift to what can he actually do? What are the abilities that we can develop in him? All this easier said and done. Not one person can do it. It has to be a collective effort from everybody. So that is the thought behind this conclave, to bring together people, stalwarts who have been working for several years in this field, to get all their input and try to put together a life course framework for the children on the spectrum. So this is in brief. This is actually just to set off. It is based on this study that Dr. Leena and myself have sat together and planned all the panels, so that we have tried to cover all the areas, and we have tried to include people with a lot of experience, including our own sir, Professor MKC sir, Dr. Safar. Lot of people from all over the country have come here. So I hope this will be a very fruitful 2-day session where we gather information and we create a module for them. I welcome all of you to this conclave.
Thank you so much, Dr. Deepa ma'am, for that incredibly moving introduction. Thank you for reminding us that collaboration isn't just a professional goal, it's a human promise to our families. As we look to understand the vast spectrum of this condition across a person's lifespan, we look to a profoundly revered pioneer to guide us through session 2, Autism Spectrum Disorder, across the life course, from early identification to adult outcomes. We are privileged to hear from a deeply inspiring foundational pillar of Indian pediatrics. His transformative, timeless, and endless compassionate life work has literally rewritten the handbook on how we protect and nurture child development in this country. He's an extraordinary academic force, holding a rare Doctor of Science degree in medicine, and serves as the former Vice Chancellor of the Kerala University of Health Sciences and Emeritus Professor Research. As the visionary founder, director of CDC Kerala, he relentlessly worked towards developing new screening tools and innovative training methods for over 3 decades, and is now globally acknowledged as a pioneer in the field. A national authority with 173 publications and 22 medical books, he currently directs the NIM Spectrum Child Development Research Center. Ladies and gentlemen, please bring your hands together and extend a resounding welcome to a peerless champion of neurodevelopment, the teacher of teachers, and an absolute titan of our fraternity, Professor Dr. MKC Nair, sir.
Good morning. I think we heard a wonderful talk. 15 minutes, but it was superb. Yes or no? A standing ovation to the director. Why I said superb? Because it brought in the emotional content. It was not facts and figures. It was more of emotional content of a parent with a child with ASD. Next 15 minutes, you will not see any emotion. You will just see only facts, just facts and figures. Because that is also important. You must balance these two. You can't get emotional all the time. You need to understand what happens to this child, whatever data that is available. Next. So sorry. Bottom one? Okay. Now, in simple words, what is ASD? ASD involve heterogeneous but recognizable key events. Mark the word heterogeneous. No two ASD child is same, entirely different. You cannot have one policy for all of them. We can have a policy for the group, not for all. Dynamic changes in symptom expression. Mark the word dynamic. It is never stable. It keep on changing. Keep on. You progress, then you take 2 steps forward, then 4 step may come down. In between, if you stop therapy for 2 months, everything is gone down. Outcomes vary based on cognitive level, especially if you are IDD or language problem. Mark my word, you cannot get good results. Early intervention quality. Every study, meta analysis shows that early intervention makes a difference not only in the initial stage up to above 65. Of course, co occurring conditions and environmental support. Now, what are the core autistic symptoms? I will put the whole talk into two types: with intervention, without intervention. First, let's see without intervention. What happens to them? Symptoms more stable or slower to change, lower rate of optimal outcome, which means without intervention as a whole at any age, you are not going to have better result. You are going to have a stable means it remains like that. You cannot change. But with intervention, variable reduction in severity over time. Some children show meaningful improvement or optimal outcome. Optimal outcome means do not show ASD criteria. Do not meet. Mark the word optimal outcome. If you have optimal outcome, that's all what we never try to make the child normal because it's never going to be normal. Some leftover of autism will be there even at 80 years. But you can have remove the ASD symptom criteria. That is important. Then let's look at what cognitive ability. Without intervention, smaller or slower gains, larger gaps related to peers often persist. Between two peers, the gap will keep on increasing. That's the problem. I always say, if you put your hand like this, here also is 30 degree, at the tip of my finger also 30 degree. But the implication change. At the beginning, child only need to feed some small activities. So that's okay. But by the time he become adolescent, his implication becomes so wide that we believe the child has deteriorated. No, actually, the child has not deteriorated, but the expectation from the child has changed. With early intervention, average gains of 9 to 17 points. We can sit the whole day and argue whether this 9 to 17 is okay, correct or not. But point is, every study will say entirely different. So this is a sum total statement. Some children reach near typical range. That is very important. In fact, that is my aim in life. In autism, when we treat, how many children can we put in school? And we have a series of children that we were able to put into the school. That is the most important. So early intervention has to be directed towards creating an environment that is exactly same like the school. So when they go to the school, they have the same, they understand what you are talking. Language and communication. Without intervention, greater persistent delays, slower progress in joint attention and conversation skills. Three things we are saying. Greater persistent delays are there. Joint attention progress is very much slower. Conversation skills are poor. Smaller or slower gains and larger gaps related to peers. Huge gap between peers. But with early intervention, we can bring significant improvements in expressive, receptive language and social communication. And that is exactly what the parents want. But mind you, what is important is social communication, not expressive, receptive language. There is a feeling that child should be speaking. No, child need not speak. He can take his own time to speak, but he should be able to communicate from the day one, or of course, it can't be from day one, at least from day 3. You get that? Day 3 means not the day 3, but after you have at least 3 months intervention. Communication has to come. Mark the word communication. It is a mistake, misnomer that we should have language developed. You don't need language, you know. You don't need so much language, but a person should be able to communicate to be effective in society. That's the most important. Mind you, all this data are meta-analysis or systematic reviews. I have not quoted any single study because there are plenty of single study, but that will not give the overall picture. Every slide is meta-analysis or systematic review. Motor skills and challenging behave without intervention, higher rates of persistent behavior challenges for some. With early intervention, modest improvement in motor skills, reductions in some challenging behavior. We tend to forget the motor skills, but the motor skill also is important, particularly the fine motor. If the child has to do well in school, we need to have at least the fine motor skills much better. So let's also focus not only on communication, but also on motor. That is, which is something that most of us don't do enough. Adaptive daily living skills. Of course, this we do a lot. Without intervention, slower acquisition, higher ongoing dependence. So you are sure that if you don't offer early intervention, child is going to be a dependent child, not a normal child. Whereas with intervention, you can show clear gains in self-care, socialization, practical skills, and better maintenance of themselves. All the slides have shown effect size and all. I don't want to bore you with all that because it will take away the fun of the talk. But it is there. How much effect size is there in each of these studies, I have put in below that. So with intervention, self-care improves, socialization improves, practical skills improve, and better maintenance. Come what may, if you do intervention, this will happen. Some more, some less. The fight is only about my model is better or that model is better. Every model is good. It's a question of how much you eat, 3 idlis or 4 idlis, that's all. The difference is only between that much. This is an important slide. Of course, it is not based on absolute data. It is also little bit computer trick, okay, where they are extrapolated available data into population. What you see in the bottom line is you will see the natural event of all the people. Then you have two lines. The straight line is for ASD overall. The dotted line is ASD plus intellectual disability. So what is important is intellectual disability and language become, I said it earlier, remember, intellectual disability and language become the key marker of good or bad performance. But unfortunately, we cannot do intellectual assessment of intellectual disability in every child with ASD because it is different. Okay? now, now let's go into the age trajectory. Till now we talked about domain specific. Now let's talk what happens 0 to 5, the area where most of us are now working on. Without timely intervention, there is delays in social communication, adaptive skills. And the intervention is for group therapy or individual therapy, all of us by and large use the same technique. Early intensive, why I'm saying this more, because most of the studies we give, which gives globally acknowledged big systems, most of them are talking for bigger children, not for early children. Okay, and that is why it is important to focus on 0 to 5. Early intensive intervention started in 0 to 5 is strongly linked to better long-term outcome. Every study has shown that. Hardly any study which showed not a single study which shows bad result, but all have done somewhat good or best results. And intervention groups show accelerated skill acquisition and reduced development lag. That's what we want. This is a meta-analysis result. And our NIM spectrum CDRC is having a huge follow-up now. And the pre-post improvement clearly shows 4 TABC, Trivandrum Autism Behavior Checklist groups, all have shown improvement. Okay, and 15 cars individual items have shown improvement. In fact, years ago, one of the PG DCCD, PG Diploma in Clinical Child Development student had done a study, which I usually show, which clearly showed that TABC, it gives tremendous result, but at that time, one item out of 16, 15 or 16, one item did not show improvement. That was intellectual. But now, with improve, because of that lesson, we have added items for intellectual improvement or cognitive improvement, and now all the 15 items not published, just waiting for the sample size to increase. Now, school age 6 to 12, what happens? Entry into formal education or special education. Both are okay. Both are okay. But what parents want is normal education or inclusive education. Now, inclusive education, very nice to talk about in big forums, but not easy to practice. So what Government of Kerala has done, of course, again, doesn't mean that is the best. What they have done is, in a city, one school is focusing on ASD, one school is focusing on ID, one school will focus on CP, like that, so that the parents, even if they have to travel a little bit, they can go to that center and you get little more better result. Not perfect, but little more better support from special education teachers. But the problem is special education is the most ignored area in our country. We don't do enough special education. They are not recognized as specialist therapists. The problem is 95% of people are only for intellectual disability, few for hearing, very few for ASD. That situation has to change. We need to focus on special educators much more than what we are doing now. Now, entry, academic, social, and behavior demands increase. We know that. Your child is normal. A normal child also, he is very good. The mother will come and say, sir, he was first in LKG, UKG, class 1, class 2, or blah, blah, blah. But after class 4, suddenly he is doing very badly, not doing very well. So what is happening there is, after class 4, there is a lot more intellectual part comes, thinking part, cognitive part has to come. Otherwise, you just mug it up, you can get result. So parents will be very good at that. Now, coming for a ASD child, this is even worse because they have the intelligence but not work properly at the right time. They have savant skills, they have exceptional intelligence sometimes, but it doesn't work at the time when they need it. So naturally in the school, they get thrown backward. Shows some gains in communication and adaptive skills, but problem is co-occurring condition like ADHD, anxiety, sensory issues, epilepsy often become more apparent. And for all pediatricians, there is only one panacea, risperidone. You write morning, evening, and afternoon, you write risperidone without thinking whether it is required or not. But having said that, I will say it is better than not writing, because risperidone probably is the only one accepted, except clonidine. These are the only two things FDA approved, Government of India also approved for all symptoms of ASD, whether it's hyperactivity, whether it's social problem, whether it's anything. Normally, we don't recommend. Of course, psychiatrists may have different opinion, but normally don't recommend specific drugs for hyperactivity like we do methylphenidate and all, except in exceptional cases. So it's okay, even if the pediatrician is prescribing left and right. Ultimately, for the family, it is not bad, although professionally it may not be the right thing to do. So, school age 6 to 12 years, they have delayed intervention is linked to greater ongoing support needs, and for a subset, adolescent social challenges. Suddenly, things become, it was okay, well managed, mother could do everything, everything was going well. Now, the adolescence has upset the whole thing. So, a small proportion, this create problem. Intervention focus is now not group therapy, it is skill building, social skill training, and supports inclusion support strategies. We need to think of that is where the parents have to come together. Nobody in this world is interested in the autistic child except the mother and occasionally the father. No other person. If anybody claim I am so much interested, no. Your interest is 10 minutes for a pediatrician, okay, and 20 minutes for a therapist. Because after the 40 minutes, 20 minutes without the mother, child will be anyway crying. So what you get is 10 to 15 minutes for active therapy. So it's a mother who has to. So that is the thing that I am working on now. And I think that is a huge directional change that is going to come. And the directional change is that the mother should become therapist. And this is what day one, 1987, August 1, when we started the Child Development Center, we proved early stimulation is effective. It's not our therapist who did the job. It is the mother who did the job. But the therapist, every month when they come, you teach them. If the mother is not doing, we put in a Likert scale. If it's not doing well, then the other mothers will help. We never teach them, you are not done well. Other mothers say, I have done like this. It worked well. So it becomes nice. Then we showed on TDSC, community is working or not. Then we showed for speech and language, 10 reels IQ points, so like that, it is mother-oriented or parent-mediated intervention. And the chapter, thank God, our president is sitting here. Chapter has accepted parent-mediated intervention as a number one strategy for neurodevelopment. Yes, sir? Yes or no? Yes. So that is a parent-mediated, which doesn't mean that we underscore the importance of therapists. Mind you, that is not what we mean. The parent he has 24 hours, 365 days, or at least 18 hours, 365 days to do it, whereas therapist has only few minutes. So children with early intensive intervention enter school with stronger cognitive, language, and adaptive foundations, facilitating academic and social progress. I never said this will become normal. I only said foundation become more strong so that later on they can pick up. Now, if you take young adults, and adolescents, young adults, 13, 24, there is shift in presentation of ASD. Some continue with steady gains, rising social complexity and peer demands. It creates mental health risk. What was okay till yesterday now will not be, because even if he want to improve, his peers will not allow him to improve. So what you will have? Anxiety, depression increase. So if you are a person looking after them, think of the psychological problem. And in fact, that is what is happening here. Saturday, we have a pediatric psychiatrist come here for children to help us with these children. Transition planning intensifies 14 to 16. You cannot talk of the school system alone, something transition planning. Vocational assessment, independent living skills. So you can't, unlike US or other countries, we cannot put the child for 100% independent thing. But we can give them supported, supervised, 2 days stay outside, 3 days stay outside, 1 week stay outside. Slowly the child learn. Then it become 1 month, maybe even more, 3 months. Like that, independent staying. Then post-secondary education, employment goals. Now, no intervention, these outcomes vary in education, employment, living arrangements, relationship, and ADL. Relationship is a huge issue. Relationship. And how do you know? We just, when the child comes, we just ask, how is your girlfriend? Huh? Look at the response of the child. You know what is his relationship strategy. What do you understand by relationship at adolescent age? You don't say you have a girlfriend or not. You just ask, how is your girlfriend? Is she okay? Is she doing well? So the fellow, the way he will look at you, understand whether it is there. Intervention focus is transition from pediatric to adult medical care. So you cannot achieve transition with a medical professional. They are fantastic for you, not for the adolescent. So I think pediatricians have to have the transition. Then with intervention, higher IQ, better language, milder early symptoms, and strong these are the ones predict greater independence. You want to see, suppose the mother asks you, will my child have an independent life or not? 3 things you say. If you have higher IQ in the beginning, You have a better language capacity, and the symptoms initially were milder. That means TABC, you don't go to 50 plus, it will remain in the 30 to 40. Then the child has improvement. 3 points. Severity of social I'll leave that. Okay. Long term school to adult without early intervention, greater risk of persistent high support needs, lower independence, and poor function. We understand. Gains often with intervention, gains often maintained or continue. So they have better adaptive functioning, lower symptom severity, high independence, employment, and reduced support needs. This is what the parents need. They don't want an increased IQ, they don't want an increased DQ, they don't want social quotient or any other multiple intelligence thing. They want the child four things: better adaptive functioning, lower symptom severity, high independence, and employment. Now, 25 to 60 years, naturally data is much, much less. So whatever we say is not 100% cannot be true. Some skills follow an inverted U pattern, which means gains into the midlife followed by leveling in mid decline. It may go like this: lot of gain, then come down, then it may pick up again. Health issues and medication use increase, mental health problems become more prominent, focus shift from work stability, relationship, housing, and long-term support as family caregivers age. Again, without intervention, I'll say with intervention. Without intervention, with early intervention, key predictor of better adult outcome is, as I said earlier, if you have high independence, employment, quality of life, and lower residential support needs. Older adults 16, again, extremely very poor data. Health disparities increase as the age goes. Cognitive changes. On the other side, dementia start coming in. In fact, dementia may come little early for these children or these adults. Support needs often rise, and whereas the family caregivers dwindle, they go melt away. There's hardly anybody, and still quality of life varies widely and depends on lifelong support, health, and social connections. Okay, 60 plus, better not to say anything. We only can offer psycho education, help them with like any other elderly, old person can be done. Improved knowledge and acceptance of autism diagnosis, and some benefits for coping. What is the fun? After this, whether you accept or not, what difference it makes? Can't say that again, because all the mental health problems and comes at that age. So if they accept it, it will reduce the mental health problems. Now, two slides I'll just say, I won't go into details. What are the causes across all the ages which determine mortality? Dominant cause is epilepsy, accidents in the early stage. In the 13 to 29, again accidents, suicide, and neurological conditions. Now, if you take mid-adulthood, cardiometabolic disease, respiratory, and external causes like accidents and suicide. Older age, again, it is cardiometabolic and respiratory infection. We have data on all this. That's how the summary has been made. Now, the last one, summary points, last but one. I know so much of data has been pushed on you. It is not possible for you to remember. By the time you remember something, the next one comes, you forget the previous one. So I am summarizing what we should remember. 0 to 5, if you give intervention, it shows accelerated skill acquisition and reduced development lag. That you can remember. 6 to 12 years, intervention group enter school with stronger cognitive, language, and adaptive. Anybody want to take photograph of this, you take it. Because it's the only thing you need to remember. All the rest, I was just giving data to support that. Is all. Whatever I'm making statement is supported by umpteen number of meta-analysis. But this is the only thing you need to remember. 13 to 24 years, social reciprocity and communication continues to improve, but adaptive skills sometimes plateau in the late. Why adaptive skill plateau? Because the adolescent issues come up. So whatever they were adapting, okay, but now the new things has come, so it became plateaued. 25 to 60, early intervention, the predictor of lower support needs, higher independence, employment, quality of life. All these are depend on early intervention on. And the last, of course, 60 plus, it will be improved knowledge and acceptance of ASD diagnosis showed some benefits for coping. If they can accept that what is the problem, then it may be easy for them to accept, cope. Thank you. Thank you very much for a patient reading. Okay. Go. 20 minutes more time left. Other speakers on the no, this is a little boring subject. Yours was fantastic slides. But I don't believe in chat GPT. So it can't make it beautiful, but I want stuff to come. So that's why I cut. I think we can take it. Why waste time? I purposely cut it. Because too much you can't keep hearing this data too much. We can create a discussion if you have time.
Thank you, sir. Yes. Yes, sir, for sharing your priceless wisdom with us. We are deeply indebted to you for always leading our fraternity from the front. If anybody wants to ask any question to sirs, it's welcome here.
But yeah. Anybody? I think we can have some comments. Starting from Madam.
No, actually, sir, it's a question rather than a comment. Because I would love to.
Questions, you ask my students.
No, sir. I am your student, and I prefer to learn from you, sir. So it's actually a question, sir. You had pointed out so many sensitive issues regarding the preteens and adolescent age groups, sir.
Yeah.
So I would like to have some insight, a little more insight regarding how can we help these children, evolve. Not in a normal way, but of course, become a little bit more self dependent, and particularly handling those pubertal issues which we come across when we see the adolescent, ASD particularly. So, sir, I would like to you to throw some more light on it, sir.
Our expert is sitting here. Please stand up, sir, for a minute. Let people see you. Sir, you. Huh?
But sorry, sir, I came late. So I can.
What is it?
I came late.
You came late, but you can answer the question. Just think of it. I will start answering. You can answer more. Remember, adolescence is like I must have taught you 30 years ago, same thing. Adolescence is like you're very difficult to do kuchipudi. You know that on the ground. Very difficult. But if you do it on a revolving thing, it becomes even worse. That is the answer. The even normal adolescents find it difficult to handle it. Now, ASD child will find it so difficult. The reason being, even normal ASD children, so-called normal means the usual ASD children. Why do they misbehave? Why do they show aggression? Why do they show all these things which make our life miserable? Because they are not able to communicate what they want. Okay. So communication, so we have, people have realized so many new gadgets, all that. I don't believe in them. Unless it is for rare cases, please sit. For rare cases where no speech is going to come. So their frustration, even otherwise it is this much, 50%. On top of it, adolescent issues, it becomes even more. And we never understand, as parents, we are gungs, I will say. We never understand yesterday also had a child and a parent who doesn't understand that, child has such problems also. Very bad, he said. I said, he is doing only what you have been doing all your life. Why don't you understand the situation of the child? He has so much of problem, difficulty in handling peers, difficulty in interacting with other people, difficulty in handling his sexual urge. It is like that water, the sea. So much of pressure. How does he manage? Normal child may learn to hide some of it, but this fellow doesn't even know how to hide. So he'll behave inappropriate, and then he becomes a bad child. Okay? Anybody and everybody. I always say, are not comfortable with your own sexuality, so you cannot be comfortable with your child's sexuality. A mental retarded child is easy to manage because you have two type of parents come. One will come and say, so he is masturbating, I want to die and all that. I said, if why you want to die for the child doing it? That is his birthright, forget it. But on the other side, there will be children, mothers who will so accepting. He says, sir, I know it's all normal. It's okay. So what do you advise them? Go and do it in the bathroom. But here, this child doesn't even know what does he want. He doesn't even know that. Okay, sir, you want to add comment? He's the behavior specialist here.
The problem is that usually.
Yes, sir. Introducing Dr. Jaiprakash R, sir. He is the professor of pediatrics and an expert child psychiatrist and the brilliant chief of the behavioral pediatrics unit at ASD Hospital. Yes, sir. Your comments.
Thank you. So usually we come across many children who are, as sir said, masturbating, especially intellectually disabled as well as autism, children with autism, they're masturbating in front of others. So that is a very difficult, emotionally very difficult situation for the parents. What to do with this? So we all come across that kinds of issues. Apart from that, they are having the the communication difficulties are there. So usually adolescents will have some negative behavior or aggressive behavior or some difficulty to handle the situations, especially when the normal, so-called normal adolescents. But in children with autism or intellectual disability, how to handle this? Actually, sir already discussed. So we have to accept the parent, we have to educate the parents that it is a normal process. All children, all adolescent children are masturbating, but they know that it should be done in a private situation, privately. But these children, children with autism or other intellectually disabled children, they will not be knowing that it should be done in a private situation. So suppose a child is masturbating in the hall or in the room and your parent is also sitting, you can leave the room, or you can take the child to toilet and leave the room, or like that. If you do it repeatedly,
Just
child.
sir, one sec. Just tell him you piss in the toilet, you pass stool in the. This also do it there. That is appropriate, but not in public. Do you do it in in the drawing room? You don't. Go there. That's all. So as simple as that.
So
That's a child will understand.
through repeated intervention like this without any emotional expressions, naturally child will get the idea that this should be done in a private room or in some other place who the other people are not there. So through the repeated behavioral intervention without emotional outburst or getting difficulty, so we have to accept that, we have to educate the parent that it is a normal process, all are doing it, but some these children, they don't know how to do it in a private situation.
Sir, if
So
the
that,
parent have become comfortable with
yeah,
the masturbation,
yeah,
all other problem they will be comfortable.
yes sir,
Because somehow we are not comfortable unless you have been working in the behaviors pediatrics. So pediatrician may be comfortable, but other doctors also may not be comfortable. So one more point I will say,
yeah.
if you want to understand the difficulty, we had somebody doing PhD in the niche where all the students are deaf, completely deaf, but they are doing undergraduate. So they was doing a PhD work. It didn't get completed. Somebody was doing it. So I went there to teach. I will say in local normal language, the other person will do the sign language. I was shocked to hear that what a school child now knows, those things also they didn't know. So I said, how come it is? It's because we never learn anything by somebody telling you what to do. We learn from sign language, all sort of language other than the oral language. We learn all this from something from the movie, something from here, something from there. We understand a lot of things, and the way other people, the friends are talking about it. But these children don't hear anything, so how do they understand? Even if they see something, they can't relate to the thing. So this is the important problem. If that much is the problem of hearing impaired, then the problem will be much more for autistic who has so many faculties, but they don't gel together at the right time when they need. That's it. Thank you, sir. Thank you so much. Excellent comment.
Thank you,
Any
sir.
other question? Please, madam. Madam, when the time is up, you tell me. Ah. Yeah, please give a comment.
Yes,
Please
sir.
give a comment.
Sir, I'm a speech language.
Introduce yourself.
I'm Dr. Lakshmi S. Mohan. I'm a speech language pathologist working in the Department of Neurodevelopmental Science niche. So the question was on the how we will be prepared on the adolescents regarding the sexual behaviors. So in children with ASD, they have a condition called problematic sexual behavior. So I have attended one course done by Dr. Nandita ma'am. It's a Sedu organization where they have, as you rightly said, their problem
She
lies
is
in
the expert in
yeah.
subject. She was my student in testing his teacher. Huh?
Yes. So,
She has attended all
yes.
this. I
So
know.
I
Okay.
have, I have seen the improvement in the children because after attending the organization one workshop, what really it is, as you rightly said, we have the child has difficulty to communicate what was to express. So the parental education has to go in two direction. One, to educate the parents to prepare for this, and equally how to educate, how to make their child understand that these are the what they're expected to do. Rightly said, the public place and private place, they don't know the discrimination between the two. So this organization, they have developed a chapter like how it has to move forward. So I just started implementing in children with autism spectrum disorder around 5 years of age, and we started from at a smaller level. Now they know that what is safe, what is unsafe, what is private, what I can do in the private, and what I
What is
cannot.
appropriate, not safe.
Yes.
Appropriate and what
Yes.
is not
Yeah, what I
appropriate.
can do in this place and all. So we have a platform and we have the resources also. So the thing lies in how we make the parent to understand or to communicate with the child. For that, we have to give the training. And I have seen improvement in the children we
The men
attending.
sitting here will understand if you have gone to a theater for movie, the break, you know, the elderly people come, stand there for some time, close it and go back because they can't initiate. But how will they tell people, fellow pushing from behind, go move, move, move? Can he do it? This is the flight of these people, understand? Just
Yes.
like an elderly person cannot initiate, urination when he wants it. These children also have that problem.
Yes.
So they will wet the place, they will do nonsense later, but you can't blame them because they don't
Yes.
have control of
Very
all
true.
this.
Yes, yes, very true, sir. It's like just like how to communicate. Like suppose in between the theater also, if the child has to go to them, child can communicate with the mother.
The children can always do like this and all. A mother immediately pick up. But an elderly person, most probably a respectable person, I'm not talking about me. I have not reached that stage.
Yes,
But
yes,
it becomes very, very difficult. So we must understand these sort of difficulties of an or that's why I said 60 plus autistic
yes.
people. The problems are triple layers are there. Okay. Thank you, madam.
Thank
Thank
you,
you
sir.
so much. Any other question if your time allows?
Thank you. Thank you so much for the wonderful discussion. Thank you, sir.
Time is out. Okay, thank you. You can thank me also, madam.
Thank you so much,
Ah,
sir.
okay, okay.
Yes,
Thank you.
we are deeply indebted to you for your wonderful words. Thank you, sir. Next, to address the next section for management of medical comorbidities in autism spectrum disorder across the life course, we are joined by an exceptional leader who seamlessly balances pediatric care with national policy development. Holding a PhD in developmental pediatrics, he brings over 2 decades of dedicated service to the specialty. Please welcome the Honorary Secretary of the IEP Chapter of Neurodevelopmental Pediatrics, Dr. Lal Devi, sir. Dr. Lal serves as the Program Director of the IEP Fellowship at Savita Medical College, Chennai, and is the Managing Director of the Vistara Child Development Center group across Chennai and Hyderabad. At the national level, Dr. Lal also serves on the Executive and Fellowship Accreditation Councils for the Indian College of Pediatrics. A pioneer in digital health, Dr. Lal also directs MilestoneBooster.com, an innovative online development assessment and therapy platform. He is the co editor of the Indian Journal of Developmental Behavioral Pediatrics, and his contributions include authoring 3 books, drafting 3 national consensus guidelines, securing 5 patents, and publishing 56 papers in index journals with over 1,000 citations. Ladies and gentlemen, please join me in welcoming our esteemed speaker, Dr. Lal Devi, sir.
Thank you. So today's my topic, Dr. Deepa madam has allotted for me, is we are starting with the comorbidities right from the start. So actually comorbidities in autism spectrum disorder is not an exception. It is a rule to be. I mean, if I want to be concrete, it is a rule rather than an exception. And these comorbidities rightly so, she has chosen the topic as comorbidities across the lifespan, because the co-occurring conditions will emerge and shift from early childhood through adolescence. It will be a different presentation, and when it becomes adult, it will become totally different comorbidities. So I have subdivided the comorbidities into three age groups, where early years 2 to 5 years, and school age 6 to 12 years, and adolescence 13 to 21 years. So the big picture is that some literature says 80 percentage. Latest one from Nature says 90 percentage of autistic children have at least one co-occurring medical or psychiatric condition coming in their lifetime. So the different what you call comorbidities can be subdivided mainly into three, where you got a neurodevelopmental psychiatric. I've clubbed them together, though many of you may not agree with me. So I put ADHD, anxiety, depression, OCD, oppositional disorders, behaviors, and other things in one group. Then we have got the neurological, where you've got epilepsy, seizures, motor coordination problems, and dyspraxias as the second group, along with the neurological. And the third one, medical and somatic, where there are a lot of GI disorders, including constipation, including functional gastrointestinal disorders, other things coming up over there. Then sleep disruptions due to 3-4 causes are there for sleep disturbances, and then feeding difficulties which are happening in these children. So the comorbidity patterns, what I mean to say, is not a static one. It is a mix of conditions which changes as the children grow, and it is driven by three factors. One is the brain development that is happening. Second one is the communication skills or the communication skill deficits that they may be facing, and therefore they may be learning things the aberrant way. And self-awareness. So as these children develop the self-awareness, the comorbidities that you see in the younger age will not be seen in the older age group. So why this comorbidity profile shifts with age? It can be explained by 4 developmental drivers. For example, the diagnostic visibility. When we enroll these children into the school, we've got a structured school environment which unmasks the so-called inattention, which the parents may be tolerating in their home. But when you enroll them into the school, suddenly the teacher finds fault with the attention and other problems. And therefore, what happens is it comes to limelight, and similarly oppositionality. So the ADHD detection, if you see the data in the school, it peaks between 6 and 12 years. So that is the diagnostic visibility that is because of which this is seen. The next one is the neuronal maturation. Epilepsy in autism is strongly age linked, with the second peak occurring around puberty. The first peak in the 2 to 5 years, and then in the puberty. Then we have got the hormonal and the pubertal changes, where puberty, as you all know, will affect the mood regulation, will affect the seizure threshold, what we call as the catamenial seizures that we have in the adolescent girls starting coming up during that period. And then we have got the changes in the sleep architecture, especially so when they get so addicted to the mobiles and viewing reels and other things. So what happens is those changes happens, because of which the pattern changes. And finally, growing self-awareness. Adolescents will become increasingly, they will perceive the social differences and by peer comparisons. Because of this, another set of things becomes quite evident. I'm not telling that anxiety will not be evident before that. But yes, during adolescence, the anxiety and depression will emerge in a very obvious way for anybody to see, to appreciate it. That is why it is becoming more evident during that particular period. So this is the 4 developmental drivers which I can say, which makes this profile change with age to age. Now, if I take the 2 to 5 years, whatever be the diagnostic paradigm or therapeutic paradigm that we are taking at this age, it is in this age group, most of us will try to somehow pinpoint the cause. We have to find out what is it a metabolic disorder? Is it a genetic disorder? These are the things which will be going in our mind. So we go in for organic, biochemical, and neurostructural etiologies to find out what is that, which is deranging this early neurodevelopment and behavioral homeostasis. So in the early years, between 2 and 5 years, this is harder to diagnose. Why? Because of the age. Second one is because of the atypical presentation. The somatic and early behavioral signs are already common. For example, if you take, many of them will have sleep and feeding issues. But what we have to understand is these sleep and feeding issues appear little before the language or the social differences in the autism becomes fully evident. So 38% of the preschoolers show at least one co-occurring psychiatric conditions. Around 29% shows signs of ADSD, ODD, or social anxiety symptoms. I'm talking about this particular age group, not the entire thing. Okay, and then 86% in the 2 to 5 year old experiencing sleep disturbances, and 70% showing gastrointestinal feeding difficulties. So now that shows how the presentation varies in the 2 to 5 year age group, where the feeding problem, if you see, it is just 14% versus 1.4% in a non-autistic peer, and sleep issues again 14% against 0.9% in a non-autistic peer. So it is already elevated in the 2 to 5 year age group. You have got social anxiety, ADSD, and other opposite defined symptoms is seen roughly about 29% in these preschoolers. So what is happening here? If first, I am not telling that you should go and do all these investigations. What I'm telling is, once, because my topic has to be coming later, it is preponed, so that is why it is occurring a little bit odd. So ideally, you should be doing all the screening, you should be doing the development assessment, you should be going ahead with confirming the diagnosis. Then you have to see what are all the things that you can do for the child. How do I plan for this? And then you have to think about what could be the factors which will be hindering my interventions. That is when we are thinking about all these other neurological investigations, biochemical investigations. Or if you are seeing a totally atypical presentation in an autistic child, that is when we go ahead with this biochemical GI screening and neurological investigations. The investigations you have got are video EEGs or organic acid, amino acid panels, etc. So all these things should be actually coming after your screening, after your diagnosis, and all those things, or there should be a real justifiable reason for you to proceed ahead when you are suspecting a genetic syndrome. For example, if you are thinking about tuberous sclerosis, or you are thinking about Fragile X, in such conditions it's justified. So why these comorbidities emerge in this age group? There are 4 mechanistic drivers over here. The in thing right now is the gut-brain axis immaturity, where we have got the altered, gut microbiota, motility, visceral hypersensitivity. All these are proposed to be leading to early GI symptoms. But these children do not know how to communicate, and therefore it will manifest in front of us as behavioral correlates. For example, irritability around the mealtime, or avoidance of certain food items, which we will be sometimes misleadingly telling as a sensory issue. It's not that sensory issue is not there. It is a definite concern, but sometimes these things are misleadingly told as sensory issues. Second one is the circadian and melatonin dysregulation. So there is a lot of evidence as of now to show that endogenous melatonin secretion in these children are deficient, and there is irregular circadian signaling in these young children. Now that partly explains why the sleep onset is late and maintenance also becomes a little bit difficult. Then we have got the shared genetic or syndromic overlap. As I've already told, 40% of the Fragile X syndrome will be autistic, but only 4% of the autistic will be Fragile X. Okay, so that is why I'm telling you, you don't have to do the investigation unless and until it is clinically evident to you. Okay, 40% of the Fragile X are autistic. Okay, but only 4% of the autistic are Fragile X. So you don't have to go in for a Fragile X screening in all the autistic children. That's what I'm trying to tell you. And then sensory processing deficiencies. You have got hypo or hyper reactivity to sensory inputs, which will contribute to some small group of feeding selectivity, sleep resistance behaviors, etc. So, but they will be mimicking anxiety before the anxiety can be formally diagnosed. This is not the age group where even a psychiatrist will feel confident about diagnosing anxiety disorder. That's 2 to 5 years. So the key point here, what we have to see is that the physiological things, for example, the sleep, the gut, the genetic or the sensory wiring, etc. These are all the key drivers of comorbidity of this age group. And therefore, it is not the medicine, it is the psychological approach that you can do, is the environmental modification that you can do that should occupy the prime interventions during this particular age group. So what to monitor and when to monitor, this is already known. Most of the pediatricians, all the pediatricians are doing this growth and nutrition at every visit. Sleep, there's a CSHQ, a questionnaire, which is really available. You can download and score it. Or you can have the structured sleep diary from the mother at every visit. GI symptoms, you can directly ask the questions about constipation, reflex abdominal pain, or its behavioral correlates, and a developmental regression. Now, I am not talking about the sleep regression, I mean, the speech regression that happens in autistic children. I am talking about the non-use of the hands and things like that, where there is an unexplained or an atypical loss of language. A child who was talking suddenly stops talking after a seizure and things like that. So there you have got social motor skills. You have to do a urgent workup, for example, metabolic screening, EEG, and genetic testing at that time. All autistic children should undergo audiological and vision screening at least at the time you make the diagnosis. Ideally, it should be done before you say it is autistic. Then lead and iron studies, especially in history of pica and other restrictive diets. When we take up the infancy and this early childhood, I've already told you there is a change in the gut microbiota and there is impaired mucosal barrier. Now, this is the one which is magnifying the so-called incidence of chronic constipation, GRD, and FGIDs. So the clinical presentation in non-verbal toddlers, this is a physical distress from the GI inflammation will manifest obliquely as acute behavioral regressions or self-injurious. They will be pounding their abdomen, or there will be an unexplained nighttime awakening. So we will be now putting we'll be putting a melatonin tablet or something like that, or maybe a sleep medicine, something like that. So this would actually be due to a GI issue. Similarly, in these cases, if we are suspecting, it is better go for a pediatric gastroenterologist's opinion. Especially, for example, there are some newer tests which are called as fecal calprotectin. If it is between 50 to 100, it is sure that it is not an inflammatory condition. It is a FGID or a irritable bowel syndrome sort of things. Whereas if it is more than 250, you have to strongly suspect an inflammatory bowel disease, and therefore they may suggest a colonoscopy. These are the things which gastroenterologists do. What are these harmful bacteria? Is an increase in the pro-inflammatory bacteria, this specific group of bacteria. And then there's something called firmicutes and bacteroids ratio. There will be an increase in the firmicutes. And these are things which are documented in different studies, and the decreased beneficial bacteria. So these are the GI gut microbial changes that you can see. Next, we come to this epilepsy and focal seizures. Here, there is an excitatory inhibitory imbalance that is causing the problem. So the clinical presentations in this age group manifest as tonic-clonic events, subtle absence seizures or atypical absence seizures, subclinical focal dyscognitive seizures that are frequently misattributed to daytime dreaming. We will tell that the child is simply sitting and dreaming, or some staring spells as in the case of absence seizures. So the neurological management, ordinary EEG, it may turn out to be normal. So better take a video EEG, 24-hour video EEG in such cases. If you are getting history of an isolated paroxysmal epileptiform activity, the first line anticonvulsant, as you all know, may be levetiracetam, valproate, etc. Except for those conditions where you suspect mitochondrial inheritance. How do you suspect that? It's very simple. After a viral fever, the child takes long time to recover. After a viral fever, the skills that are learned are lost. Again, the therapist has to retrain. So these are conditions which suggest a mitochondrial etiology plus hypotonia. So in such cases, better avoid valproate. So specific medicines we will have to, there are certain medicines which we will have to avoid, which will exacerbate, for example, phenytoin, phenobarbital, such things has to be avoided. So how do you, sometimes it's very difficult to distinguish this particular focal seizures, what we previously called as complex partial seizures, from a behavioral stereotype, for example, a motor mannerism or a stimming. So how do we do that? See, most of the time, if we are okay with it, we can go. Otherwise, we should get a neurologist consultation from that. Because both these phenomenon will present as unresponsiveness, staring spells, repetitive mannerisms, etc. So the neurologist will go in for what they call as a multi-axial clinical diagnosis, where they subdivide into 5 axes and all those things that a neurologist does, and EEG, what you call testing. So as a developmental pediatrician, what we will do, we have to go, the step 1 will be a macro behavioral and an environmental evaluation. What is triggering this particular thing? This is something which we have to understand, because putting a drug and sending the child home is pretty easy. But
if the environmental trigger is persistently there, for example, somebody is sitting and watching a motor racing in the TV and the child is sitting like that, it's going to trigger again and again a seizure. So we have to understand such environmental, we have to do an environmental evaluation as developmental pediatrician before we are ordering any advanced neurodiagnostics. And so that we can map out the physical constraints and other ecological, context. Then the best thing that we can do is what you call as an interruption protocol. When the child is showing something, you are suspecting that this is a seizure, you just touch or hold the shoulder of the child. So if the whatever the child is manifesting is suddenly stopping, then it is not a seizure, it is going to be a stereotypy. So in that way you can distinguish a behavioral stereotypy from a focal seizures. So when you suspect such an event, is a tactile or sensory interruptible or impervious? If it is impervious, you have to evaluate for focal seizures. If it is interruptible, you go for stereotypies evaluation. Then I come to the sleep-wake cycle alterations. We have got protracted onset latency. We could fragment the sleep architecturally, getting up in between, and then decrease total sleep duration. Three things you can see in the sleep. So, okay, if I can use some good English or high English, it's called chronobiological optimization alongside targeted pediatric neuropsychiatric pharmacotherapy. Now, this is what sir was telling. Okay, good luck to you. Okay. Okay. So what I meant is, it's very simple. Before you go for any psychiatric pharmacotherapy, please understand the chronology. How is it happening? Why is it happening? And all those things. You optimize those things. Okay. Meanwhile, you may be putting some medicines. Don't go in for polypharma just like that, fatafat like that. So that is something that we have to do, because they do not need such medications for the sleep. If at all everything fails, the comforting, everything fails, then you can go for an immediate release melatonin tablet. The side effects are not there. In fact, we can say around 30 minutes prior to the intended sleep. That is the gold standard initial compound in this age group. But what we have to understand is, for if the sleep onset latency is persistent, these are the children who may be having what is called sympathetic hyperarousal. So if that's the case, then an alpha 2 adrenergic agonist, especially if this is an ADHD with hyperactivity, if you put this, both the hyperactivity will reduce and the sleep problems also will be reduced, because here it is because of the sympathetic nervous system preventing the autonomic shift to parasympathetic dominance, where you take the rest and you say sleep. So the nocturnal, how do you do that? When you monitor the child's heart rate, nocturnal tachycardia will be there. Just before you go to the sleep, when the child falls asleep, just before that, you will see that the heart rate comes down. Nowadays, you have got the thing which you can fit in the finger, and you can monitor it is not rocket science. Previously, if it is ICU, you get the dabba thing. Now you have in the fingers also, you can just put like that and you can monitor, and you can see the dip in that thing. You will see during the bedtime itself, the child's face will be flushed as if he is angry. Okay, that means there is a sympathetic overdrive. And another thing that they do is, you can see whether how much the child is moving the wrist, as actigraphy, which they scientifically do. But we can monitor otherwise also. If the wrist movement is too much during the sleep, then he's having a problem with respect to sleeping. So we go for different interventions in this age group. You all know EIB and AB are the ones. Speech and language therapy for communication, and OT for sensory and motor feeding. So what happens here is that you have to go, when you give the occupational therapy, what is happening is you are teaching the child to self-integrate, okay, to integrate with self, okay, because if if some gurgling is happening in your stomach, you cannot be sitting here. So you should first learn to regulate yourself, so that you should integrate yourself with this particular group when your stomach is gurgling. Okay, that's not possible. It's a very difficult task. So that skill the child has to get, and that is why the sensory or OT interventions plays a role there. PMIs, parent mediatic training programs, ESDM style coachings, etc., will be building the communication. Sleep behavioral interventions, for example, a consistent bed routine. We last month we had a very good discussion about the sleep problems from Dr. Deepa Madam herself. In fact, it was aired pan South Asia. Okay, so in fact, some of these things are taken from her talk only. That feeding, extinction protocols, stimulus controls, and light exposure, all those things. So the feeding therapy you can initiate or get the help from a dietitian or an OT. But the pharmacotherapy, I've already told you why. Because see, they will be having a regurgitation when the child lies down, and therefore the child will find it difficult to sleep. Okay, so we have to evaluate all these things when the child is having a sleep problem, not just one brain melatonin is not secreting or less. Don't think like that. It can be other things also. So melatonin is the first drug. There is no other FDA approved medication before 5 years. For difficult behaviors, if you are having, they say risperidone or aripiprazole can be given as there is any self-injurious behavior. This is the, I'm not talking about the sleep, I'm talking about the in general the interventions. So the medication in preschooler is an exception. This is something which we have to have. We are not putting medications, okay? It's reserved for, because there will be threatening behavior, safety issues and other things, and therefore it is an exception. When you come to the middle age group, 5 to 11 years, here the problem is the endogenous dysregulation that is happening because of the so-called neurotransmitters. Okay. So you are seeing here, what you are seeing here is a totally different comorbidity profile where 96% will experience more than one comorbidities throughout. 50% will meet the criteria for ADSD. That's the most common single diagnosis as comorbidity. 85% in this particular age group will have a co-occurring language disorder, and 30% will have intellectual disability. So the anxiety is somewhere around 20%, learning disability again 20%. Epilepsy prevalence in this age group is somewhere around 13% as they are school going. It starts increasing again, starts increasing. And GI symptoms and sleep problems, which was there in 2 to 5 years, often persist, but underreported in this age group. So why these comorbidities emerge like this between 6 and 12 years is because of the academic structured settings demand. So you need a sustained attention. You need to retain things in your memory when you are writing. You need to remember 3 words, or you need to remember 5 letters of a word to write. Otherwise, you will be copying letter by letter from the board. So working memory is needed, and self-regulation demands for the classroom. All these things will unmask the ADHD and the executive dysfunctions that you can see in these autistic children, which may not be apparent when they are at home. That is something which we have to understand. We will tell that it is find fault with the teacher. No, the teacher is telling the correct thing, but it is unapparent in your home. Okay. Second one is the rising neurological risk. As I've already told, the epilepsy incidence increases as it climbs through the middle age group. And you're having low IQ, language regression history, all those things coming up over there. Peer comparison will start. They are self-aware. They are aware about their difficulties. So what happens is when peer comparison begins, early social comparison with same age peers will start to generate the first recognizable symptom of anxiety in these children, though depression remains rare still at this age. Then persisting GI and sleep disturbances, which will continue like that. We take up the ADHD in this particular thing. I've already told about the severe executive dysfunctions that you get. Pervasive kinetic, hyperkinetic behaviors and profound selective inattention will all interfere with the academic and adaptive learning. So it is not just the academics that is important. You have to learn, you have to have the adaptive behaviors also to conduct yourself in the classroom, to conduct yourself with the peers and with the teachers. That's something which we horribly miss when we are training the child to send to the school. Adaptive is not just eating, drinking, and things like that. Adaptive things inside the classrooms are also there, which we'll hardly train. So the development behavior management as pediatrician, if you are going for a pharmacotherapy, then they go in for a stimulant drug with behavioral intervention. Well, there are stimulant drugs and non-stimulant drugs. I'm not going into the details of that. But yes, guaifenesin or clonidine will be preferred if it is a ADHD with autism. So those are the different drugs that are there. And when it is used, the first line is always methylphenidate. However, we would prefer atomoxetine in these situations, especially if it is not tolerated, because sometimes, especially methylphenidate, shouldn't be putting if there is a 40% of them have silent seizures, that is electrical activity. Some of them, 30% will have manifest seizures. So in such situation, if you put methylphenidate, it will worsen the seizures. So you shouldn't be putting that. So you go in for atomoxetine and things like that. So thus irritability and aggression, we go in for risperidone or aripiprazole. The practice point is the response rate is somewhere around 60% versus 20 to 30% on placebo. So that is when you are putting this about these drugs I am talking. So then we come to the metabolic monitoring. Once you put risperidone, once you put all these drugs, then what is it that you will do? You have to monitor the side effects also of these drugs. So, for example, valproate or risperidone will cause increase in weight. So we have to monitor the weight, BMI, waist circumference, etc. They are getting into adolescence. So it is good to reduce the weight, height, and all those things, or to prevent from becoming obese at this age, rather than when they go in for adolescence and then trying to control all these things. It is a bad practice. So preventive thing, or primordial prevention, if I can put it that way, will be far better than controlling the weight, height, etc. in adults and all the comorbidities, BP, etc. I'm sure Sir might have told about low birth weight going in for developing obesity and other things. So the fasting lipid panel, these are some of the things which you can do. There's the AIMS, or abnormal involuntary movement scale, and that is free of cost actually, which we can do every 6 to 12 months. An epilepsy, when you will suspect, is when there is a staring spells, unexplained regressions and motor automatisms, or some nocturnal, he was having good control and suddenly it is losing the nocturnal control. So this is where we have to go in for EEGs. And children with intellectual disability will have a higher incidence of epilepsy. And if two age-related incident peaks are described, early childhood and around puberty. So if there are focal signs, if there are significant regressions and atypical seminology, then go for MRI. Don't just like that, go ahead with MRIs. And screen for treatable causes in this particular age group. So the first line I've already told us this thing, levetiracetam, lamotrigine, and valproate. Be cautious about the hepatotoxicity in these children, especially if you are putting valproate. Then the anxiety and specific phobias. Here what happens is, see, our amygdala is creating anxiety. Our prefrontal cortex is telling you, hurry, don't worry. So if there is a problem in over here and you cannot think properly, automatically your anxiety will peak. That is why this, don't think that anxiety is happening because they do not know how to speak. That is not the case. Okay, so it is the imbalance over here which is causing the social anxiety or a profound separation anxiety. See, 1.5 years you will see separation anxiety, but that will persist in these children. You will see that they will be crying till the mother comes. Okay, so the behavioral avoidance, somatic complaints, etc. will be coming in this, because you can expect them to cry in the LKG, not in the second standard, third standard as you leave, continuously crying when the parent leaves the child. Okay, so we have to go in for a modified CBT in these cases, which will be structurally adapted by the developmental psychologist. I am specifically using the word developmental psychologist. And modifications to eliminate these abstract metaphors, relying instead on explicit concrete rule-governed structures, will do a lot of help in these cases. If severe anxiety restrict the basic functional capacity, then you can go in for a psychiatric consultation. They may be putting some SSRIs in such cases. Then here also sleep problem comes. Here you get a new staring spells, again as regressions, etc. You go in for the sleep management, as I've already described all the sleep management things. The first line sleep management is, okay, bedtime resistance. Transition is issues if you are seeing, think about bedtime resistance. High alertness, hyperarousal will lead to delayed sleep onset. Out of sync biological clock will lead to night waking. So these are the issues and the reasons why it comes. And therefore, in a preschooler, going for co-regulation, absolute routine consistency, and sensory environmental control. Whereas in a school going, you have to use cognitive tools, screen time boundaries, because if you see the mobile and you sleep, the blue light will prevent the melatonin secretion from the pineal gland. You cannot sleep. This applies for us also. Then social narratives, you can tell the social stories and other things, or things like that, and address peer-related performance anxiety, because anxiety can also be causing an issue with respect to the sleep in these children. So this is how in a preschool and in a school going child, the sleep issue has to be managed, not just comforting, not just specifying, not just giving some blanket alone. You have to address the other things also. So you co-manage with neurology. The pediatrician's role is early recognition, referral, and monitoring for these sleep issues. So the primary root cause, uh, in the toddler or preschool, behavioral resistance, missing transition cues, and basic sensory discomfort. When it comes to school age, you get cognitive hyperarousal, school anxiety, screen time interference. So the causes are different in this two age group for the sleep disturbance. The communication tools, what you can use is basic picture schedules and physical guidance for correcting it. Social stories, visual checklists, and verbalized copying strategies for school age children. The caregiver's role, what the mother should be doing, direct co-regulation for a preschooler, physical presence, and gradual extinction. Whereas for a school age child, it is facilitating independence, setting structural boundaries, and emotional debriefing. When it comes to what you call incentive structures, immediate, tangible, that is something I'm giving, you have to give it then and there itself for a preschooler. Whereas when it comes to school age children, delayed gratification via token economy systems and rewards will work. Then the nap intervention, adjusting the nap times to preserve nighttime sleep. You don't allow the child to sleep in the evenings and things like that will work up in a toddler or a preschool. Whereas completely discouraging or eliminating a daytime napping for a school age children. So the management itself is different in these two age groups. Now we come to the adolescents 12 to 17, 24% anxiety, 13% depressive disorder. You are finding an increasing depression now. 26% epilepsy and 22% OCD spectrum and anxiety. So those are the most frequent psychiatric symptoms in this particular age group. So you can see that the anxiety is now climbing to 23%, 18 to 21 versus the non-autistic peers. You may sometimes see something like this catatonia, a treatable presentation of market slowing, mutism, posturing. If you are seeing that, very, very, very rare. I'm not going into the details of that. But suicidal risk is something which we have to consider in these children. Why these comorbidities changes between 13 to 21 is a pubertal hormonal change, as you all know. Second one is the social comparison and camouflaging, where the adolescent increasingly notice the social difference. Many engage with what is called as an effortful masking of their autistic trait. This happens especially in girls. Okay, they will. It's very difficult to get them the autistic traits in mild autistic children, especially when they go into the adolescence. It is strongly this particular behavior is linked to anxiety, exhaustion, and depression because all their mental energy is directed towards somehow masking this particular thing and escaping from this unworthy society that they feel exhausted. All right. So then we have got the second epilepsy incidence peak that is happening and an increasing executive things which are needed for the exams, relationship maintenance, etc. So the pubertal endocrine fluctuation, behavioral activation, you avoid via low and slow SSRI titrations if the medications are there. For catatonia, motor stasis, etc., you go in for a high dose lorazepam. Now you take up depressive disorders, mood. That is not our domain; it is psychiatrist domain. That's why I'm just brushing it off. Just we have to know that. That's all. Then a major depressive disorders and mood dysregulation. You get prominent psychomotor agitation. You get prominent social withdrawal, a severe irritability that is happening, and suicidal ideations are all happening. So, deployment of structured, validated tools adapted for neurodevelopment differences is what we have to do. We shouldn't be using checklists in these cases. One common mistake which we do is using checklists, generic checklists. It is better we use validated tools for in these conditions because of obvious legal implications. Now, the anxieties and specific phobias, they present as behavioral avoidance, somatic complaints, etc. This I think I've already told you. I'm just repeating it in this particular age group. That's it. So then modified CBT, how do we will be doing is by ASD adapted CBT methods are there. As you all know, visual supports, reduce reliance on abstract cognitive researching, etc., and parental involvement. Now, epilepsy, I've already told you, because why I'm putting it again here is because we would be giving a lot of medicines over the years. It will have an impact on the bone health. So that's something in epileptic children we will have to see in these cases, especially if somebody has inadvertently put phenytoin, etc. We have to be looking at that drug
Sorry
levels
to
and these
interrupt,
things.
sir. Kindly be reminded you have 5 more
Yeah.
minutes.
No, I'm finished. So now we come to AFRID. Okay, avoid and restrictive food intake behaviors. So here what happens is it will lead to nutritional deficiencies. It is not just avoiding some food. There will be nutritional deficiency in addition to avoidance. There will be a profound weight loss. There will be total dependent on oral enteral supplementations driven by acute aversion to a specific olfactory, visual, and textile elements of the food. Please do not label this as a sensory issue. This is a totally different, what we call psychiatric disorder, what we call as apharit. So the pediatric medicine leads to what we have to do is systematic monitoring. We have to monitor the electrolytes. We have to monitor the cardiac arrhythmias, etc., bone density measurements. All these things, as a pediatrician, we will have to do. And then, of course, feeding protocols, desensitization. So now you can understand that if somebody is sending this child telling that there is oral hypersensitivity for sensory integration therapy, you are in fool's paradise and you are killing the child, because the child is definitely going to die because of cardiac arrhythmias or some electrolyte imbalances. So we have to be very careful in this sort of conditions. So beyond behavior, we have to look at the physical health. Now, I'm coming to the end of this thing. In the early years, screen for feeding, sleep disturbances at routine pediatric visit, watch for early ADHD, ODD, and social anxiety type behaviors. I'm not telling social anxiety type behaviors. Diagnostic tools are less valid at this age, so you have to monitor and reassess. When it comes to school age, attention, learning, and language is the thing. So prioritize ADHD and language and learning evaluation in school planning. Track for emerging epilepsies with regressions and lower IQs. Introduce anxiety screening alongside academic support. Don't just go in only for academics, concentrate on that. You have to go in for this anxiety that comes because they are finding it difficult also. In the adolescents, you concentrate a little bit more on mood, anxiety, and seizure risk as well as suicidal risk. So those are my references. Thank you.
Thank you, sir, for the incredible presentation. We kindly request Dr. Deepa Bhaskaran, madam, for felicitation, Dr. Lal, sir.
These are all drawn by a child on the spectrum. He's actually here. We will see him later on. 10 minutes questions to Dr. Lal.
Yes, sir.
I mean, if you can answer questions.
Yes.
The forum is open for questions. Do we have any questions for Dr. Lal, sir?
Yes, ma'am. Yes, ma'am.
Diagnosis of OCD versus autism, or autism
Okay.
and OCD.
Ma'am, for autism, we have got specific criterias. For ODD is also specific criterias. OCD. So, no. See, the confusion comes when I am obsessed with something and I want to have it persistently. Whereas in this autism spectrum disorder, OCD is not about one specific thing or something like that. Whereas in autism, it is the repetitive nature of the behavior. It is not limited to certain things like, for example, hand washing. The child will not go and repeatedly do the hand washing in the case of an autism, whereas that they will be doing in a obsessive compulsive disorder. Whereas in autism, the repetitive nature of the thing is the behavior is for self gratification or avoiding certain things. Whereas an OCD is never, the intention is never to avoid certain things. It is that I'm unsure whether I have done, so I repeatedly go on doing the thing. That purpose is not there in the case of a repetitive behavior in the case of an autism, where it is either to avoid an interaction or mingling or things like that, or self gratifications where the 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 problem starts from the lower brainstem region where the repetitive things are stimulated, and that is not the case when an OCD I mean, when you are talking about physiologically also, the level of the what you call, from where it starts in the brain, it is different. So location is different. One is from the cortex, the other one is from the below the area, and the second one is the intention is different. The third one is the nature or the way in which the repetitive things happening is different. Whereas in OCD, I am doing some ritualistic behaviors. I'm doing something because I am unsure, not because I am enjoying. Whereas in the case of repetitive behavior, in the case of an autism, I want it, I am really enjoying it that way. So uh, the by these three things we can differentiate whether this is an OTC, whether there is separate DSM criteria for OCD that is totally different from the repetitive things in autism.
Yes. Thank you. Thank you so much, sir. To lead us through session 4, Assessment and Management of Autism, are we meeting the best standards? We are transcending borders and connecting live across time zones to welcome a truly phenomenal global authority. Coming to us from the University of New South Wales, Sydney, Australia, please give a warm welcome to the Scientia Professor of Chair and of Child Psychiatry and Dr. Valsamma Eapen. Her staggering academic legacy features over 500 peer reviewed journal articles, 7 books, and research grants exceeding 40 million Australian dollars. Just this year, in 2026, she was honored as an Officer of the Order of Australia for her distinguished service to child mental health and neurodevelopmental research. Closer to home, her work deeply resonates with our local mission as she created the groundbreaking Quality of Life in Autism Spectrum Disorder questionnaire, which our very own CDC has translated and validated in Malayalam. Ladies and gentlemen, please extend a resounding welcome to a true global luminary, Dr. Valsamma Eapen.
Recording in progress. Hello, Dr. Deepa.
You're audible, Valsa. Yes, madam, you're audible.
Can you hear me?
Yes, ma'am. Yes, ma'am.
I'll try and share my slide and see how I go.
Yes, ma'am. Slides are visible, madam. Slideshow, if you can put it in slideshow.
Yeah.
Thank you, ma'am. Thank you.
Enough?
Yes, ma'am. Yes, ma'am.
All right. Okay. So what time am I starting?
You can start now, ma'am.
Okay, and then I'll finish. So it's if you say 2:40.
40 minutes from now, ma'am.
So that will be 3:20 for me.
For you,
So I
ma'am.
think I stop at 3:15 for questions for 5 minutes. Okay.
Yes,
all
ma'am.
right.
Yes.
So when you're ready, you can ask me to start. Yeah.
Um,
Yes, ma'am, we can start now. Yes.
All right. Thank you very much for having me. Today I'll be talking about the assessment of autism spectrum disorders, and I will be using the best standards. I'm also Leap and I am Professor Charles Carty at UNSW Sydney.